Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's discussion is on surgical aspects of intestinal tuberculosis, lymph node tuberculosis, and pleural tuberculosis. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. Tuberculosis or TB is a widespread problem that affects nearly one-third of the world's population. It is a multi-system disease with myriad presentations and manifestations. It is classified as pulmonary, extrapulmonary, or both. Extrapulmonary TB may occur in 10 to 40% of patients. In the present lecture, only extrapulmonary TB will be discussed. The extrapulmonary sites most commonly involved in TB are the lymph nodes, pleura, genitourinary tract, intestine, bones and joints, meninges, peritoneum, and pericardium. Infected end organs such as the kidneys, bones, meninges, eyes, choroids, and the abscess of the lungs typically have high local oxygen tension. Risk factors for developing active disease after mycobacterial infection include malnutrition, tobacco smoking, pulmonary fibrosis, alcoholism, HIV, diabetes, silicosis, immunosuppression, particularly TNF-alpha inhibitors, cancer of head and the neck, hematological malignancies, end-stage renal disease, chronic malabsorption, and gastrectomy. TB is commonly caused by Mycobacterium tuberculosis and occasionally by Mycobacterium bovis, Mycobacterium kansasi, Mycobacterium fortuitum, Mycobacterium marinum, and Mycobacterium ulcerans. Mycobacterium bovis is characteristically resistant to pyrazinamide and is transmitted by unpasteurized milk. Mycobacterium tuberculosis is a slow-growing, obligate anaerobe and a facultative intracellular parasite. It is a rod-shaped, non-spore-forming, gram-neutral as well as acid and alcohol-fast bacteria. Their cell wall contain mycolic acid-rich long-chain glycolipids and phosphoglycolipids that protect mycobacteria from the host cell lysosomal attack. Acid fastness is due mainly to the organism's high content of mycolic acids. Acid-fast pathogens other than mycobacteria are Nocardia braziliensis, Rhodococcus, Legionella mygdadi, and the protozoa Isospora and Cryptosporidium. Immunocompromised patients are additionally susceptible to tuberculosis infection. HIV infection is the strongest risk factor for developing active tuberculosis. Tuberculosis of cervical lymph nodes, pleura, and the small intestine is the main area of concern for a surgeon. The infection of Mycobacterium tuberculosis begins with inhalation of infected droplets from a diseased patient by a close bystander. Mycobacteria are highly antigenic and initially mount a vigorous non-specific immune response. Their antigenicity is due to their cell wall constituents such as glycoproteins, phospholipids, and F.I.A.G.E.S. These activate Langerhans cells, lymphocytes, and polymorph nuclear leukocytes. In the very early phase, the predominant cells infected by Mycobacterium tuberculosis are dendritic cells. The dendritic cells activate CD4 plus T helper or Th cells through interleukin 12 pathway in lymphatic tissues. The CD4 plus cells then migrate to the site of infection and activate macrophages. This causes accumulation of lytic enzymes and regulatory molecules such as tumor necrosis factor alpha and transforming growth factor beta, leading to granuloma formation. Surfactants also play a role in the interaction between the host and the pathogen because surfactant protein D prevents phagocytosis. Phagocytosis is enhanced by complement activation products such as C3b and C3bi. Mycobacterium tuberculosis bacilli disrupt phagosome maturation through activation of the early secreted target antigen 6 secretion system 1 or ESX1 secretion system, delaying the T cell responses. Immunity to Mycobacterium tuberculosis is primarily mediated by Th1 cells, which stimulate macrophages to kill the bacteria. About 3 weeks after infection, a Th1 response is mounted that activates macrophages, enabling them to become bactericidal. Differentiation of Th1 cells depends on interleukin 12 and interleukin 18. Th1 mediated macrophage activation and killing of mycobacteria is mediated by interferon gamma. Interferon gamma stimulates maturation of the phagolysosome in infected macrophages, stimulates production of nitric oxide, which is important for killing of mycobacteria, mobilizes antimicrobial peptides such as defensins against the mycobacteria, and stimulates autophagy. Autophagy destroys damaged organelles and intracellular mycobacteria. Mycobacterium tuberculosis has many strains that differ in virulence and are capable of producing a variety of manifestations of disease. Mycobacterium tuberculosis genome was decoded in 1998. Since then, different patterns of virulence have been identified in various animal models. The CART-G gene protects the pathogen against oxidative stress and is required for isoniazid activation and its bactericidal activity. The RD1 locus on the Mycobacterium tuberculosis genome plays a crucial role in its virulence. RD1 contributes to cell death and cytokine secretion in infected macrophages. It encodes the ESX1 secretion system, which is also a major virulence factor. RD1 leads to maturation and secretion of interleukin 1 alpha from infected macrophages by enhancing calcium influx. Research in RD1's role in pathogenesis may help identify novel approaches for treating and preventing tuberculosis. The absence of RD1 locus in the Mycobacterium bovis BCG genome contributes to BCG's effectiveness. RD1 is a fascinating area of research towards understanding the pathogenesis of tuberculosis. The mycobacterial virulence is also influenced by mycobacterial protein CAR-D expressed by the CAR-D gene. Protein CAR-D is essential for the control of ribosomal RNA transcription that is required for mycobacterial replication and persistence in the host cells. Its loss predisposes mycobacteria to killing by a variety of host defense mechanisms. The innate resistance to infection with Mycobacterium tuberculosis is polygenic in nature because there is differing amounts of susceptibility to tuberculosis in different populations. Natural resistance associated macrophage protein 1 or NRAMP1, which is located on the short arm of chromosome 2, plays a regulatory role in resistance and susceptibility to mycobacteria. In addition, polymorphisms in major histocompatibility complex alleles, interferon gamma, T cell growth factor beta, interleukin 10, mannose binding protein, interferon gamma receptor, toll-like receptor 2, vitamin D receptor, and interleukin 1 have been associated with susceptibility to tuberculosis. The characteristic lesion of tuberculosis is a tubercle, which is an avascular granuloma. Granuloma formation is the hallmark of mycobacterial infection. A granuloma has a central zone containing multinucleated Langerhans giantcells with or without caseation necrosis surrounded by a rim of epitheloid cells, dendritic cells, B and T lymphocytes, and fibroblasts. About 2 to 4 weeks after infection, two host responses to Mycobacterium tuberculosis develop: a macrophage activating response and a tissue damaging response. The macrophage activating response is a T cell mediated phenomenon. The tissue damaging response is the result of a delayed type hypersensitivity reaction to various bacillary antigens. The latter causes caseous necrosis of the involved tissues. Due to the development of a specific immunity and the accumulation of large numbers of activated macrophages at the site of the primary lesion, granulomatous lesions or tubercles or granulomas are formed. At this point, some lesions may heal by fibrosis with subsequent calcification, whereas inflammation and necrosis occur in other lesions. The lymph node TB is common in the Indian subcontinent. The lymph node disease is particularly frequent among HIV-infected patients as well as among children and young adults. Lymph node TB presents as painless swelling of the lymph nodes, most commonly in posterior cervical and supraclavicular sites. This condition is historically referred to as a scrofula or collar stud abscess. In the abdomen, tubercle bacilli enter the mesenteric lymph nodes through the Peyer's patches present in the terminal ileum. The tuberculous mesenteric lymphadenitis presents with abdominal pain, vomiting, and slight tenderness in the right iliac fossa, mimicking appendicitis. Negative Robsing sign, normal pulse rate, and absence of high leukocytosis go against the diagnosis of appendicitis. Usual test findings are raised ESR and C-reactive protein, low hemoglobin, and a positive MON2 test. But the MON2 test is not reliable in a patient from an endemic area. The MON2 test or tuberculin skin test has now been replaced by interferon-gamma release assays. In the early disease, lymph nodes are usually discrete, but later develop into a matted non-tender mass. In late stages, a cold abscess may form. It is a painless and fluctuant swelling which is not warm and there is no sign of inflammation. If left untreated, the cold abscess may burst into the space just beneath the superficial fascia. This gives rise to a bilocular mass with cross fluctuation. This is known as collar stud abscess. A sinus tract draining caseous material may also result over time. A tuberculous sinus typically has a watery discharge and undermined edges. Associated lung disease is present in fewer than 50% of cases, and systemic symptoms are uncommon except in HIV-infected individuals. The diagnosis is made by fine needle aspiration biopsy with a positive result in up to 80% cases or by surgical excision biopsy. Typical caseating granulomas with or without visible acid-fast bacilli are seen in a vast majority of examinations, and AFP cultures are positive in 70 to 80% of cases. Differential diagnosis includes neoplastic diseases such as lymphomas and metastatic carcinomas, and rare disorders like Kikuchi's disease or necrotizing histiocytic lymphadenitis, Kimura's disease, and Castleman's disease. Treatment is mainly medical. Systemic anti-tuberculous chemotherapy should be instituted. Therapeutic regimens effective for pulmonary infection can be applied to tuberculous lymphadenitis. Surgery is reserved for establishing the diagnosis, advanced disease, persistent disease, or a draining fistula. Involvement of the pleura accounts for about 20% of extrapulmonary cases. Isolated pleural effusion occurs due to recent primary infection. Fluid in the pleural space represents a hypersensitivity reaction to mycobacterial antigens. Pleural effusion may also be secondary as a result of a nearby pulmonary focus. The effusion may be small or may be large enough to cause symptoms like fever, chest pain, and dyspnea. Physical findings of pleural effusion are dullness to percussion and absence of breath sounds. Chest X-ray reveals the effusion. Aspiration of pleural fluid or thoracocentesis is done to ascertain the nature of the effusion and possible etiologies. The fluid is typically straw-colored. It is known as an exudate if its protein concentration is more than 50% of that in serum or more than 4 grams per deciliter. Its glucose concentration is equal to or lower than that of plasma. Its pH is equal to or less than 7.3. And its white cell count is more than 1000 per microliter. Neutrophils may predominate in the early stage, but lymphocytes predominate later on. AFBs are rarely seen on direct smear. Pleural fluid adenosine deaminase concentration may be a useful screening test, and TB may be excluded if the value is very low. Interferon gamma measurement can be diagnostically helpful. Pleural tissue biopsy and culture is recommended over pleural fluid analysis for diagnosis. It reveals granulomas or yields a positive result in up to 80% of cases. When nucleic acid amplification methods like expert MTB or IFSA is used, pleural biopsy can yield a positive result in about 75% of cases in a very short time. Expert MTB or IFSA simultaneously detects Mycobacterium tuberculosis complex and resistance to rifampin in less than 2 hours. This test has higher sensitivity in smear-negative TB cases and among HIV-infected patients. Pleural TB responds rapidly to anti-tuberculous chemotherapy. Concurrent glucocorticoid administration is not of proven benefit. Tuberculous empyema usually results from the rupture of a cavity, and this process may create a bronchopleural fistula with air in the pleural space. Chest X-ray shows hydropneumothorax and an air fluid level. The empyema fluid is purulent and thick and contains large numbers of mycobacteria and lymphocytes. Acid-fast smears and mycobacterial cultures are often positive. Surgical drainage followed by anti-tuberculous chemotherapy is usually required. Tuberculous empyema may lead to severe pleural fibrosis and restrictive lung disease. Decortication or removal of the thickened visceral pleura is occasionally required to improve lung function. Intestinal tuberculosis can occur secondary to an active pulmonary disease or as a primary infection without pulmonary involvement. It can involve any part of the gastrointestinal tract, but the ileocecal region is the most commonly affected site. Its presentation is usually chronic or acute on chronic with non-specific symptoms. The typical presenting symptoms are abdominal pain, weight loss, nausea, recurrent vomiting, and diarrhea. Usual complications are subacute obstruction, local perforation, and intracutaneous fistula formation. Diagnosis is challenging and often delayed due to its non-specific presentation. Intestinal TB responds well to standard anti-tuberculous drugs. Surgery is only required in cases of complications such as strictures or obstruction that do not respond to medical therapy. High clinical suspicion and early initiation of anti-tuberculous therapy are essential for reducing morbidity and mortality. Commonly affected abdominal sites are the ileum, proximal colon, and peritoneum. There are two principal types, ulcerative and hyperplastic. Marked mesenteric lymphadenopathy may occur in both types. Ulcerative tuberculosis develops secondary to pulmonary tuberculosis as a result of swelling of the sputum containing tubercle bacilli. Mycobacteria colonize the terminal ileum, causing multiple transverse ulcers with typical undermined edges. The overlying serosa becomes thickened, reddened, and studded with tubercles. The lesions show epitheloid cell caseating granulomas and multinucleated Langerhans giantcells. This severe form of the disease develops when the virulence of the organism surpasses the host resistance. If the host immunity and resistance are high, hyperplastic type of lesion develops. The ileocecal region is mostly affected. The infection localizes itself in lymphoid follicles with early involvement and caseation of local lymph nodes. There is narrowing and obstruction of the intestinal lumen due to marked hyperplasia and thickening of the terminal ileum from intense inflammatory reaction. Areas of stricture and fibrosis may occur, which are most notable at the terminal ileum. As a result of fibrosis, there is shortening of the terminal ileum and the cecum gets pulled up into a subhepatic position. Grossly, this type may be misunderstood as being Crohn's disease. But unlike in Crohn's disease, abscesses and fistula formation are rare. There is stasis and bacterial overgrowth, leading to steatorrhea, anemia, and weight loss. There may be a mass in the right iliac fossa. The differential diagnosis includes appendix mass, lymphoma, carcinoma of the cecum, Crohn's disease, and actinomycosis. Localized areas or pockets of ascites may occur in both forms. Abdominal pain, diarrhea, weight loss, anorexia, malaise, evening rise in temperature with sweating, and alternating constipation and diarrhea are common symptoms of intestinal tuberculosis. While abdominal distension, hematochezia, intestinal obstruction, perforation, and fistula formation are uncommon presentations in ileocecal tuberculosis. Obstruction from strictures and rarely peritonitis from perforation of a tuberculous ulcer create an emergency situation. On examination, the abdomen feels doughy. A mass may be felt in the right iliac fossa in the hyperplastic type. Occasionally, some patients may present with multiple fistula in ano with undermined edges and watery discharge. Abdominal pain and distension plus absolute constipation with bilious and feculent vomiting are typically present in extreme cases of intestinal obstruction. The patient may complain of frequency of micturition if there is genitourinary tract involvement. Routine general investigations show raised inflammatory markers, anemia, and positive sputum culture. Primary lung infection may be detected with a plain chest radiograph. Ultrasound of the abdomen may reveal cocoons or pockets of ascites. Interferon gamma release assays like quantiferon TB gold in tube may be used to detect a subclinical or latent infection. A barium meal and follow-through series and a small bowel enema show strictures of the ileum and typically a high subhepatic cecum and a narrow ileum. The narrow ileum enters the cecum directly from below upwards in a straight line rather than at an angle. A culture of the ascitic fluid for AFB may be helpful. Microscopy and culture of the urine is done if there are associated urinary symptoms. A sterile pyuria on examination should raise a suspicion of tuberculosis of the urinary tract. A contracted or thimble bladder and golf hole ureteric orifice may be seen on cystoscopy in genitourinary tuberculosis. A plain abdominal radiograph in erect posture shows multiple air fluid levels typical of a small bowel obstruction. Diagnostic laparoscopy shows tubercles on serosal surface, a small bowel strictures, a high cecum, enlarged lymph nodes, areas of caseation necrosis, and ascites. The first line treatment is a standard 4-drug regimen. On completion of medical treatment, the patient is reassessed clinically and radiologically. The small bowel is re-imaged to look for significant strictures. If there is subacute intermittent obstruction due to residual stricture, surgical options are limited ileocolic resection with ileocolic anastomosis, a strictureplasty, or right hemicolectomy as deemed appropriate. In an emergency patient, a thorough resuscitation for dehydration, malnutrition, anemia, and active pulmonary tuberculosis should precede the definitive surgery. The resection should be kept as conservative as possible. The optimum procedure for a terminal ileal stricture would be a side-to-side iliotransverse anastomosis. Preferably, a one-stage surgery should be performed if the general condition of the patient permits. A full course of anti-tuberculous chemotherapy for up to 3 to 6 months should be offered after the surgery. After a bypass procedure, the patient is reassessed, and when the disease is no longer active, an elective right hemicolectomy is done to remove the blind loop. At this time, a strictureplasty for residual or new short strictures should be performed. Perforation is treated by resection and anastomosis after a thorough resuscitation. In an emergency situation, when there is widespread disease and heavy peritoneal contamination, resection and exteriorization is done as a first stage. The bowel continuity is restored later on as a second stage after a full course of anti-tuberculous chemotherapy and improvement in general condition.